Back to biomedical ethics. So, today we will be finishing up our week long discussion of social determinants of health, and we'll be talking about the current debate, both in bioethical circles and in healthcare circles, about the disciplines and the road ahead. So, let's get started. So, class today will be structured as follows. We'll be exploring two questions. One question that we discussed right at the beginning of the semester, our first week, when we were talking about what is biomedical ethics. And we talked about how there's this debate where there are two camps. One camp is arguing that bioethics should focus specifically on clinical issues. There are so many issues that arise in medical contexts that really we don't have the bandwidth to look at wider social and contextual factors. And then another group that's like, well, there are so many issues that influenced healthcare that we need to expand bioethics to include social factors. And so now that we've spent many weeks talking about bioethical issues that arise in healthcare settings and beyond, we'll be revisiting this question. Should bioethics be expanded to include social factors that influence clinical settings? And in addition, as the social determinants of health literature has made clear, there's a similar discussion occurring in healthcare circles. Social and contextual factors influence the health outcomes of patients. We know this. We know that the quality of water, for example, whether or not there are contaminants in the water, environmental factors, such as whether you live in urban, suburban, or rural areas. Do you live in an air quality? Do you live in an area that's prone to forest fires? Nutrition and access to housing. All of these factors influence the health of patients. But where does medicine end? Should healthcare be expanded to include these various factors? Or should we think of healthcare as something that simply occurs within clinical settings? Now, scholars such as Dr. Williams and others, as we'll see, argue that it needs to be expanded. We even see doctors writing prescriptions for foodstuffs. Whereas other medical professionals argue that, again, there's so much to do in clinical settings that we need to demarcate what is and is not healthcare because there is so much on the plate of doctors that and other medical professionals that we're just muddying the water by expanding the sphere of healthcare to include these various factors. And so we'll be exploring both of these questions today, looking at arguments for the expansion, building off of our discussion on Wednesday, and arguments against expanding healthcare and bioethics more generally. And so we already talked about this a little bit, but just to recap, because it has been a long time since the beginning of the semester, and I'm actually surprised at how quickly this semester has gone. It seems like just yesterday we were talking about what is bioethics, right? But there is a disagreement in the field over the precise limits of bioethics. You have the one side that argues that the field should concern itself with all questions involving biology and medicine more generally. Hence, we have research ethics, ethics that engage with applications of biotechnology, food bioethics, environmental bioethics, etc. And then we have others who argue that the field should only focus on a subset of these questions, specifically medicine and what occurs in the clinical setting. And we've actually read quite a few pieces by those who have a horse in the race, so to speak, like Bouchot and Childress, for example, very much support the argument that we should be focusing on clinical issues. Bioethicists should engage with the rich and nuanced and many questions that occur in clinical settings. And then we have others that argue that big data is important, biotechnology applications, food and environmental bioethics, environmental factors such as environmental contaminants, These are important as well. And Weston very much takes the opposite side and pushes back against Bouchot and Childress. Weston, in the parable that we talked about on Wednesday, is trying to convince us that social determinants of health are very important for healthcare. And we had his parable where you're a lifeguard and you're by the river and people are drowning in the river. And so you're jumping in and pulling someone out and providing emergency care. And then you see another person and you jump in and you're saving this other person and you're saving another person all the time, when you should be asking yourself, why are so many people in the river drowning? What is the cause of the cause? And as we talked about on Wednesday, Weston uses this parable to convince us that social determinants of health matter. That while healthcare and traditional bioethics focus on downstream problems, whether or not we should ration or how best to determine who should obtain care, how do we support the autonomy of our patient, is privacy being respected? Have we obtained informed consent? These are very important questions, but these are downstream questions and not the causes of causes, not the upstream causes that could be exacerbating problems within the healthcare sphere or causing novel problems within the healthcare sphere. So Weston argued that this myopic focus negatively impacts health outcomes and reduces the options that we consider when addressing bioethics dilemmas. And we talked about how this happens on Wednesday. And he ends by arguing that we should be looking at social factors. Bioethics, too, has a responsibility to raise the questions that actually matter to health. And that is a very strong statement here. And indeed, in order to perform bioethics adequately, to be a good bioethicist, we need to include social factors. So he argues that the very range of options one considers in the face of such dilemmas that we see in the downstream dilemmas, and thus the eventual decisions one might come to advocate, are profoundly changed by opening up the sorts of social questions so far suggested. And so, in order to expand the ways that we can, or solutions, potential solutions to problems, we need to include social factors for Weston. And so, thus, even to do the job that bioethicists currently set themselves to do, bioethics must pay attention to this broader range of factors. And so to be a good bioethicist, we need to look at all of the myriad potential solutions and also how social factors influence the clinical setting. This is an important component of the process. And that's a very strong argument, right? And so I'm just going to pass through. And so a similar argument has been made, as we saw, about healthcare itself. And we've been exploring this on Monday and Wednesday. And so Weston and others have argued that healthcare, in addition to bioethics, needs to take an upstream approach. And these are social determinants of health. And we talked about how substances influence the health of individuals, the safety of communities, whether you have access to healthcare, your opportunities for recreation and for exercise, whether you're living next to transportation systems. What is the quality of food that you have access to? And do you have access to food? Do you live in areas where access to healthy foodstuffs is problematic? What does your housing situation look like? Are there any contaminants within that housing context, such as lead, for example? What about children's health? Do you have access? Have you had access to health care as you've been growing up? Or has there been a dearth of access? And what are the long-term health impacts of that? Are you suffering from addiction, et cetera, et cetera? And so social determinants of health are conditions in the places where people live, learn, work, and play that affect a wide range of health and quality of life risks and outcomes. And increasingly, public health advocates and other medical professionals argue that we should care about these. And so the parable is taken as sort of a push for both bioethics and for healthcare more generally to expand its sphere. And so I have a brief video by Dr. Williams who looks at social determinants of health. And I think it's important for our discussion going forward. So I'm going to try and play it. But then I want to look at some of the arguments for expanding for expanding healthcare and bioethics, and some of the arguments against doing so going forward. So hopefully this will play. But Dr. Williams, as we'll see, said the key to improving health outcomes is not more healthcare, but improving the quality of life in places where people spend most of their time. And that gets to the heart of what advocates for SDOHs or SDHs, depending on which reading you've been looking at, for this expansion.
The field of behavioral sciences have some of the key answers to some of the major crises that the United States faces in terms of health. My name is David Williams. My work is looking at social factors that affect health. I think most Americans, when we think about health, we think about medical care. We think about access to medical care, the quality of care that we receive. But the scientific research is very clear that where we live, learn, work, and play have more to do with our health than going to a doctor. So when we talk about health and what can be done to promote health, we really need to think about the factors and the places where we spend most of our time and the opportunities or barriers in those places to lead a healthy lifestyle. Does your neighborhood have access to a full-service grocery store where you can get access to fruits and vegetables? Is your neighborhood free of crime, and is it safe to walk outside in the day? Does your neighborhood have access to green spaces and to parks and to safe places to walk? Low-income Americans are 3 times more likely to die before the age of 65 than high-income Americans. My earliest work started out looking at inequalities in health in terms of socioeconomic inequalities in health. Why does health vary by income and education and occupational status? And many people don't realize this, but the gaps in health in the United States by income and education are larger than the gaps in health by race. It's an interesting sociological question why, as a society, we've historically paid complete attention just to racial gaps in health and not to the gaps by socioeconomic status. Let me give you a concrete example. Where you live in the United States, for most people, determines where you go to school, the quality of elementary and high school education. And the quality of education then determines your access to quality higher education, which determines your access to quality jobs, which determines your access to residence in quality neighborhoods, which determines the quality of resources you have in life to deal with all the things you will encounter. In some states, there's a 13-year difference in how long people live, just linked to which county they live in. All of these are powerful ways in which our health is affected that is shaped by the context in which we live. Race has been what sociologists like to call master status, a factor that determines your access to virtually every resource within society. Generally, even when we look at Blacks and whites or Latinos at the same levels of income or education, there still is a residual effect of race. So race still matters then at every level of education and income. And that led to the question, what else is it about race that still matters so much for health? What does it mean to be African American in the United States? And how does the experience of race shape exposures that have consequences for health? The everyday discrimination scale is a 9 item set of questions that assess the way in which people are treated or ways in which people are treated in their day to day lives. What the everyday discrimination scale does, it tries to measure how their experience, the way others treat them and others view them is different. So it just captures the little indignities that occur on a day to day basis. And what we are finding is that this chronic, minor, ongoing experiences of incivility and discrimination have long term negative consequences for health. That's kind of a powerful way in which racism affects health that we seldom think about. The idea that racism has consequences for health is not new, has been around for 100 years. But the actual hard scientific evidence linking racism to actual disease processes, like processes of inflammation and processes of the subclinical development of heart disease, is new. I think one of the things that I'm doing is encouraging people to look at the intersections of inequalities, looking at race and socioeconomic status together, looking at the joint effect of both of those variables, and empirically documenting the ways in which racism affects health. The key to improving the health of America is not linked to more medical care. It's linked to factors outside the healthcare system and paying attention to improving the quality of life in the places where Americans spend most of their time: our homes, our workplaces, our schools, our neighborhoods, our communities. And if we can develop a culture of health where we can make the healthy choice the easy choice, we can put the United States on a path to better health now and for the future.
All right. So I think Dr. Williams does an excellent job of highlighting how social determinants of health or social factors more generally impact the health of populations and your patients. And so, just to pull the quote again, the key to improving health outcomes is not more healthcare, but improving quality of life in places where people spend most of their time. And so, examples of social determinants of health include the availability of resources to meet daily needs, safe housing, local food markets, etc. As he talked about, access to educational, economic, and job opportunities, and yes, access to healthcare services, quality of these various goods as well. And so, all of this impacts the health outcomes of patients. And so there's a strong argument for expanding both the healthcare sphere to include these social factors and bioethics more generally. He makes a Dr. Williams and others supporting, and Weston and others supporting this position. They make a compelling case, right? And so this forms the basis for many aid and public health programs that social context matters. And indeed, we we do not need to look very far to find examples of this to support this position. For example, there are various commissions on social determinants of health that non governmental organizations or NGOs and governmental organizations have. So, this includes the United Nations, the World Health Organization, etc. And so, just to pull from WHO's Commission on the Social Determinants of Health, they argue that, quote, the poor health of poor people, the social gradient in health within countries, and the substantial health inequities between countries are caused, so that we have a causal statement there, by the unequal distribution of power, income, goods, and services globally and nationally. So, together, the structural determinants of, and conditions of daily life constitute the social determinants of health and cause much of the health inequity between and within countries. And so there is a compelling case, and there are many supporters for this expansion of the field of healthcare to include these various factors. Now, Prada and Voigt, in the piece I had you read for this week, they are sympathetic to the cause calls for expanding healthcare to include these factors. But they argue, let's look at the argument, right? And then let's weigh the argument and let's see whether or not it holds. So we've spent the last 2 days looking at, or Wednesday and Friday, looking at some of the arguments for the expansion of both of these fields. Well, what is the argument and what are some of the counter arguments for this position? Well, Prada and Voigt argue that the argument in support of expansion includes three assumptions. One, a set of empirical assumptions that identify socioeconomic circumstances as the ultimate causes or causes of health outcomes and inequities. And so they are the upstream factors that are throwing people in the river to utilize Weston's piece. But is that the case? Because that is an empirical question. Two, a set of normative assumptions to the effect that social inequalities in health are unfair and therefore must be rectified as a matter of justice. So, is the lack of access to various social goods a justice issue? What framework of justice are we using? And we talked about many different frameworks, from Rawls, for example, to social contract theory. And so, what type of justice is undergirding these arguments? And finally, the recommendation that the best and possibly most effective way of redressing health inequalities is by wide ranging societal changes, most notably policies that address differences in socioeconomic stances. So we have the empirical assumptions, we have the normative assumptions, and then we have assumptions concerning the best way of going about addressing a problem. And so they want to talk about each of these areas to see if they hold water and what are some of the concerns about these three sets. So let's unpack the assumptions and let's look at the first one. So, a set of empirical assumptions that identify socioeconomic circumstances as the ultimate causes or causes of causes, say that 5 times fast, of health outcomes and inequalities. And so they agree that negative health outcomes are correlated with socioeconomic factors. But life is messy. There are so many factors that we're not controlling for. And so there could be various other reasons why or causes for these various health differences in health outcomes. And so is this sort of mistaking correlation with causation, right? And so they go on to argue, well, let's look at the empirical findings. So empirical data shows that European countries' social inequalities in health have persisted and even widened in certain contexts, even where the expansions of the welfare state have reduced inequalities in income and wealth. And so there are contexts where health inequalities have been maintained even when access to goods has shifted so that there's more of a universal access to goods. So what's going on here? And are social determinants then really the causes of negative health outcomes? And so are socioeconomic circumstances always the cause? And are programs aimed at addressing these a good strategy for health improvement? And so the World Health Organization and many other SDOH aimed programs tend to focus on economic disparity as a way to address health outcomes, problematic or differentials, unequal health outcomes. But one, is this simply a correlation and not a causation? And two, well, then is this actually going to address health inequalities, right? If we have circumstances or examples where we have addressed the disparity in income, but health inequalities persist. And so they want us to think more deeply about the empirical underpinnings of social determinants of health. And then there are the normative claims and the justice considerations. And so a set of normative assumptions to the effect that social inequalities in health are unfair and therefore must be rectified as a matter of social justice. And so they use Whitehead's 7 determinants of health inequalities, and they break them down into natural or avoidable and those that are unfair. So the ones that are natural, quote unquote, or avoidable are the following: biological variation. We're all born with a different potential health outcomes. And so these are something that we typically can't control for. Health damaging behavior if freely chosen, such as whether or not you want to snowboard or climb Mount Rainier, right? Or imbibe too much of a substance or vape a lot. The transient health advantage of one group over another when that group is the first to adopt a health promoting behavior. So if one group decides to totally get into like aerobics or something, and another group decides that no, aerobics is not for us, then the differential in health outcomes is avoidable. Then there are the unfair ones. 4, health damaging behavior, where the degree of choice of lifestyle is severely restricted. Exposure to unhealthy, stressful living and working conditions. Inadequate access to essential health and other public services. Natural selection or health related social mobility involving the tendency for sick people to move down the social scale. And so if you're sick and you can't work, and then that impacts economic status, and then there are further impacts that result from that. And so we have natural or avoidable, and those are seen as fair differentials in health outcomes. And then we have 4 through 7, which are typically labeled as unfair, as social determinants of health. And so concerning 4 through 7, Prada and Voigt argue that this glosses over an important debate. Does personal responsibility play no role? And so it assumes that everyone is not responsible for their socioeconomic position, which has shaped their health outcomes. And so, what role does or should social or personal responsibility play? And we talked about Knowles of no relation and other bioethicists who argue that social responsibility should play a major role in access to healthcare resources. And we have others, such as Davids, who argues that no, that social responsibility is complicated and there are many social factors that influence our choices. And so social responsibility should play a limited role in access to healthcare. And so for 4 through 7, that brings up that heated debate. And we need to engage with that debate as we're talking about social determinants of health, because it very much influences whether or not we think that health disparities are unjust, right? So it influences the normative framing of the issue. So they go on to argue responsibility is plausibly a matter of degree, and most individual behavior falls somewhere between the fully determined and the freely chosen ends of the spectrum. So if this is the case, and there's a lot of gray area between whether or not responsibility should play a role and how individual behavior is connected to individual choice versus social determinants, if it even falls in the middle, if it even falls in the gray area, then we need to rethink or have a larger discussion concerning these normative underpinnings. And then we have 1 through 4, the natural, quote unquote, as a normative criteria. And so 1 through 4, the argument is that they're fair because they're avoidable or quote unquote natural. But they want us to think about what is a normative criteria, and should quote unquote natural be an acceptable criterion? And so this assumes that natural health inequities versus social ones are acceptable. And so having, say, a disease connected, a genetic disease, cystic fibrosis, Huntington's, sickle cell, etc., are these acceptable because they are quote unquote natural? And so Prada and Voigt want us to be very careful about applying normative weight to things that are natural. Is arsenic like ethical? Well, is arsenic acceptable because it's natural, right? No one would say, oh, let us imbibe arsenic. No, no, no. Like, in fact, I am not endorsing this behavior at all, but it just sort of highlights how natural is problematic. And so, Freda and Voigt, they're not pushing completely against social determinants of health, but they want us to think more deeply about the normative components of this because it seems like it's very problematic to say that natural disorders are fair. And then there are there's the distinction between whether or not a health disparity is avoidable versus amenable to intervention. So many natural inequalities are in fact amenable to intervention. And so shouldn't they be included? And then we have avoidable injustices. So because something can be avoided doesn't mean that we should do something about it. And so, again, just like natural, should the ability to avoid, say, developing a disease, oh, well, you could have avoided that. You should not have gone out and breathed in the air when air quality is very low because we have a forest fire. And so um, that's, you shouldn't have done that, right? That's avoidable. And so there you're using avoidable as sort of a normative claim there. But in not, there aren't, avoidable isn't something that we should always strive for, right? So burning evidence would help us avoid jail time, but that doesn't mean that we should, right? And so they're quibbling, but I think they're making a very good point that many of these arguments utilize these terms and they give them normative weight, natural, avoidable, etc. But we need to think more deeply about what this means then. And so, this idea of providing normative weight to terms such as natural and avoidable is wrong-headed for Prada and Voigt. Amenable to intervention should be adopted as a stronger ethical criteria to determine fairness. And so, I said again, this is a set of normative assumptions to the effect that social inequalities in health are unfair and therefore must be rectified as a matter of social justice. And so they want us to sort of expand out these terms rather than avoidable. Well, perhaps amenable to intervention would be a better way of thinking about whether or not health disparities are fair or not fair, and which ones we should target. And so they go on to argue, well, again, aren't these matters of justice rather than simply healthcare issues? If we look at robust theories of justice, such as Daniel's use of Rawls, addressing social inequalities should be a matter of justice, period. And so it seems like arguing that social determinants of health should be taken seriously because they're connected to health outcomes is missing the forest for the trees for Prada and Voigt. So, arguing that we should address these issues simply as a matter of health misses a very important component, and that's that social determinants of health are ultimately about fairness. And so, being very clear about SDOHs as a justice argument is very important. because it's about the distribution of benefits and harms across the society, right? Who has access to healthcare? Who doesn't have access to healthcare? Who's enjoying more of the benefits of societal goods and who's incurring more of the harms? If counties, to pull from the Williams video, if you live in one county and your neighbor in the other county will live 13 more years on average because they live in another county, then that points to social inequalities of distribution of goods, and so distributive justice issues. And so Prada and Voigt argue that rather than downplaying the normative context or not being clear with our normative framework, that it needs to be robustly highlighted that these are justice issues. And this isn't being done in the literature. And so, should healthcare be expanded? Well, if we argue yes, we need to make a justice argument to support that position. All right. And so I'm not going to go into the cases, but I will put up this TED Talk video. And so this video sort of supports or pushes, actually, the doctor pushes back against Prada and Voigt, arguing that your doctor needs to know your comprehensive history, and this includes where you lived and what hazards you've been potentially exposed to in order to provide the best possible care. And so rather than it simply being a justice issue, as Prada and Voigt argues, and I use simply here in scare quotes, he argues that it is indeed a healthcare issue, that if patient health outcomes are connected to where you live, then your medical professional, in order to treat you, should have access to medically pertinent information. And so I'm curious where you stand on this. Should, one, bioethics be expanded, as Weston argues, to include these social factors? And two, should healthcare be expanded? Should social determinants of health be on the table? Is this a healthcare issue? Or do you agree with Prada and Voigt that there are problems with the social determinants of health literature? And so, should social determinants of health be seen as a health issue? Should they influence bioethical reasoning? And are the authors correct that social inequities should be seen as matters of justice rather than placed in the sphere of health? Or is that a false dichotomy? Daniels would argue that it is. And as we are mortal, everything impacts health. Where should we draw the line concerning policy? So we've gone on for quite a bit today. I've probably gone over. So I will leave you with these questions, but I am very much looking forward to reading your thoughts in the discussion forums and to hearing what you have to say as you weigh into this very contentious but very important argument that is shaping the future of healthcare in the United States and the field of bioethics. Thank you guys so much, and I'm looking forward to the discussion ahead.